Top Med Talk.
Well, hello and welcome to Top Med Talk. We are here at the World Congress of Perioperative Medicine, EBPOM 2022. I'm Desiree, Chappell, your host, and I'm joined by my co-host, Monty Mythen. Hello, Monty.
Desiree, it's great to be here. Great to be hosting you all at University College London.
That's right, here in London, the heart of London. You're where you have been practicing for and professor for.
Well, I retired from clinical practice at University College London Hospitals on the 31st of March. Still here as an emeritus professor of anaesthesia and critical care, having done my 20 plus years being, academic here and a clinician.
Yeah, and EBPOM was kind of born here in London.
Yeah, this is the birth. You see it as the sort of founding organisation for evidence-based perioperative medicine. We then formed strong partnerships over the year, particularly with St George's Hospital and then Southampton, and many international partners. But it's our 25th anniversary, so well done to everyone who continues to engage with evidence-based perioperative medicine.
Yeah, it's been a great meeting so far. We're actually on day 3.
Day 3. It's been great. It's been lively. It's been great to have a live audience back.
Yeah.
A few hundred people, a good few hundred people in the room, hundreds of people listening live online, and we know from looking at the podcast downloads, thousands engaging on the sort of follow-up component to that, because there's the live bit of it, and then there's the on-demand video and the on-demand podcast.
Yeah, and we have already been putting out podcasts throughout the sessions here, and we've done our Top Med Talks too, which is something definitely to be looking forward to.
And that's what we're here to do now. We've hung back at lunchtime.
Yep.
We've exploited the opportunity to get up onto the stage so that we could have a conversation with a special guest.
That's right. Well, it is my pleasure to introduce our guest today, Alistair McNarry from Edinburgh. Alistair, thank you so much for joining us.
Oh, thank you so much for having me, Desiree. It's so nice to see you in the flesh. Monty, I'm going to embarrass you. I think you've been a professor at this hospital for the entirety of my anaesthetic career. and I'm not a young trainee anymore. but it is so nice to be out and about, and so nice to see people, and so nice to chat to people, and discuss all those little things you never quite get over Zoom.
Yeah.
So it's lovely to see you both, and thank you for having me.
Yeah, absolutely. I think you've been a professor for as long as I've been out of training.
Let's move on from all
right.
that.
So today, we cannot do Top Med Talk without the gracious sponsorship of our partners and industry partners. And today that is Medtronic. They are sponsoring our podcast session today. Alistair, we wanted to take a deep dive on video laryngoscopy. There's been we've actually recorded some stuff in the past. There's been a lot of discussion about it since COVID. We thought it's always great to kind of regroup and see where we are now.
So I probably have to start with a confession. I'm a video laryngoscopy enthusiast.
Okay.
You won't have any difficulty persuading me to use a video laryngoscope. In fact, you'll have difficulty persuading me to use anything else. So all of my sort of comments have to be borne by the listeners with that in mind. I will try and be balanced and fair and even, but I cannot see why you wouldn't use a video laryngoscope every day of the week.
Yeah, good disclosure.
So before we get into that, you just brought me back to the last live EBPOM we had. Actually, no, we were in the British Museum, but it wasn't an EBPOM we were at. We were at a Royal College of Anaesthetists meeting, and we recorded prior to a debate between William Harrop Griffiths and Tim Cook, the pro-con of should video laryngoscopy. Now, this is pre-COVID.
Yes.
Okay, this is pre-COVID. So they had a good old ding-dong. And the interview was great and balanced beforehand. And I think we were possibly tipping William over a little bit towards the bright side, one might argue. It's going to be really interesting to try and have that conversation again post-COVID, because I think it's put it in a completely different light.
It's a really good lead in it, Monty. Thank you for that. But there are two things. I have come clutching not quite my 580 pages of this year's hot off the press, Jan Hansel-led Cochrane review on video laryngoscopy. So I'm not going to debate. I'm going to use evidence-based medicine, which I think you'll approve of. And I come clutching early results of our VLIQ study, which EBPOM were good enough to distribute to your member lips last year, about whether COVID had changed people's investigation, use, understanding of video laryngoscopy. But I think that this year, the big talk has to be about the evidence. The Cochrane review, 228 studies, it gives some real hard nuggets. It says that any sort of video laryngoscopy, and they didn't just group them all together. They said whether you've got a Macintosh type video laryngoscope, whether you've got a hyperangulated video laryngoscope, whether you've got a channel video laryngoscope, all of them reduce the risk of failed intubation.
Oh.
Boom.
Exactly.
Shall I go?
Drop the mic and walk out. Wow, so that's really interesting. We could go so many different places with that. Let's come back to all of that, because I think we need to have a discussion about what it looked like prior to COVID, what people were using, because we had some pre-discussion and we talked about kind of the history of laryngoscopy and the scopes that we are using. And I thought it would be good just to kind of go back to that for a second.
So evidence-based therapeutic medicine and airway management are interesting bedfellows, because sometimes they sit nicely and sometimes, well, you will all remember, of course, that Mackintosh's paper back in the 1940s was 1 page long and it didn't have any patients in it. And yet it's probably the biggest invention in airway management we've ever seen. Scroll forwards 40 years to Archie Brain, and his revolution, the laryngeal mask, had 23 patients. And yet they were both complete game changers. And now, of course, times have changed. We want evidence. But what's really interesting is that the Mackintosh laryngoscope has been around for so long, and we've got so good at using it that we frame everything almost in how we think about it. So if you go back and read now, Richard Cooper worked with Jack Pacey, the surgeon in Canada, to bring us the glide scope, which is really the first video laryngoscope of the modern era. And if you read the abstract of their article, they talked about intubation in about 700 patients. That focus on the article isn't about getting the tube down the trachea and administering oxygen. The focus in the article is about the change in view.
Yes.
Because with the Mackintosh, the conventional Mackintosh blade, if you got a view, you could get a tube down the hole, because if you could see the line of sight, you could put a tube there. Maybe you needed to use a bougie, but it was all about getting the view. But even then, back in 2005, there's this little line in the abstract that says, although the view was very good, in 3 or 4% of cases, we didn't get the tube in. And we kind of missed that.
Yeah.
We all got swept up in this idea that video laryngoscopy good, and it is.
Because tube deployment became the issue, didn't it?
In the early days of video laryngoscopy,
Yes.
if you read the stuff from the McGrath Series 5, from Dermot McKeown and David Ray up in Edinburgh, and they say one of the issues was getting a good view and not getting the tube in.
Yeah.
And that was a common problem.
Yes.
And I sort of think that is a hangover of Mackintosh. Because with Mackintosh, you got a line of sight, you could see where you're going, and you simply put the tube there.
Yeah.
Video laryngoscopy changed that. And I wonder, we're nearly 20 years since that paper on the GlideScope, I wonder whether it's time to have a different discussion on what a video laryngoscope does. Because a video laryngoscope, and I'm very sad about this, a video laryngoscope doesn't actually administer any oxygen.
Oh.
It just lets you put a tube in the trachea. And the tube going in the trachea, while it's beautiful to see, doesn't actually administer any oxygen either. You have to connect up. So I was lucky enough to meet Jan Hansel last week, actually, the lead author of the Cochrane. And he was fascinating. He said, look, laryngoscopy is a technique. A direct laryngoscope or a video laryngoscope is a device. And I'm going to add an extra line. It's the outcome that matters.
Yes.
The outcome is effective administration of oxygen to the trachea.
So to reiterate for us again, the result of the meta-analysis you've come holding today is?
So it's really easy. Mackintosh style video laryngoscope blades, hyperangulated video laryngoscope blades, and channeled video laryngoscope blades all reduce the risk of failed intubation.
Right.
And for failed intubation, they actually had an easy-to-use diagnosis that said more than 3 attempts or a change in operator. They also said that Mackintosh-style video laryngoscopes reduced, so the higher first pass attempt, so the first time you put the tube in, you get it in more often, and you get less hypoxemia. And hyperangulated blades, they said, produce less esophageal intubations. And we may get down to the subgroup analysis in a minute or two, but they said hyperangulated blades are by far the best thing to have in difficult airways.
Any bad news?
They're not perfect.
Yeah. Well,
what is?
But I think I'm a video laryngoscope fan. I have ambitions that by the time I retire, there will be the perfect video laryngoscope that allows you to facilitate the passage of oxygen into every trachea. But that doesn't exist yet. Video laryngoscopes still fail. When we adopted the McGrath Mac up in Edinburgh, we collected some fairly benign data. We looked at about 1,000 intubations, and about 97.5% of them, we got the tube in. Tick.
Yeah.
That's way better than sort of figures that were coming from Macintosh. The Emma study, I don't think it's made it into a proper journal yet, but at the last Worldwide Airway Management Group meeting in Amsterdam, when we were allowed out in 2019, they were saying that first pass success with a McGrath Mac was 94% compared to 82% with a conventional laryngoscope. Now, you're going to say, what does first pass success have to do with getting the oxygen into the trachea? It's that very complex interplay in airway management. No anaesthetist is an amateur at airway management. We're all very good at it. It's what we make our careers of. But actually, if you get the tube in first time, you get that little bit of bandwidth in your head, that little bit of room to behave normally, that little reduction in panic. But first pass success, it actually gives you that little bit of human factors headspace.
Yes.
If you're on your second pass, you're starting to think, what have I done wrong? What's not going to plan? Your pulse rate's just starting to go up a little bit. And we know that the more times you insert a laryngoscope into the airway, the more trauma you cause. We know from the great yellow book, the NAP4 report, the NAP4 report into complications of airway management, published in 2011, phenomenal. If you haven't read it yet, you must all go away and read it. Yeah. But most really bad situations, most can't intubate, can't oxygenate scenarios, started off as can intubate, can oxygenate.
Yes.
And that repeated
trauma.
Trauma's a really harsh word because it wasn't trauma. The anaesthetists or airway managers involved didn't set out to traumatize the airway.
No.
They set out to put the tube in. And they had another go to try and achieve that goal. Inadvertently, they caused trauma. But I think when you say, oh, too many attempts at intubation cause trauma, we're doing a whole pile of really good airway managers, whether they work in the ED or the critical care or AMOS, a disservice. Because no airway manager sets out to cause airway trauma.
Yeah.
And I suppose that's where video laryngoscope's giving you that extra little boost. You can get it in more often first time. Yeah. That risk of trauma just goes down.
We should just acknowledge in passing, we're having a very well-resourced world discussion here.
Yes.
We don't always think of the National Health Service in the UK that way. One of the resistances in the past into the discussion was the relative, we're not going to talk about price here if you see what I mean, but the acquisition cost and discussions about the economics. And therefore there wasn't universal availability in the National Health Service, for example. I don't know what it was like with you in America, Desiree. But I get the impression that tipped over in COVID to be a very different world.
Well, I did actually last night go back. In 2010, when I was doing silly surveys, we did a survey of video laryngoscopy availability in the UK, and availability was about 57, 56%. Oh. Tim Cook came back in 2014, availability was up to 91%. At the Worldwide Airway Management meeting in high-income countries. Sorry, I do other things by surveys. It just sounds like I do nothing but shuffle paper. But by then, high-income and high middle-income countries, 91 to 92% availability of VL. But here's the rub: low-income and low-middle-income countries, access to VL as high as 50%.
Oh,
yeah, exactly. Yeah. Not what you're thinking.
Yeah.
And we haven't quite pulled out the data. I'm going to give a plug to my 3 registrars, Emma, Nia, and Emma. They're busy plugging away at the VLIQ data. Somebody told me the other day there were 195,000 bits of data they were wading through. So we haven't quite pulled out the low-income stuff from VLIQ. But I get the impression video laryngoscopes are becoming, that they're not widely available, I'm not saying that, but they're becoming more available than we would have maybe imagined. And it's a difficult one. Does using a video laryngoscope decrease your skill with a direct laryngoscope? It depends on your teacher. Okay. It depends on whether your teacher teaches you what you're actually doing. Because, no offense to my teachers, they would say, put the laryngoscope in, you do that, and they say, what can you see? and for your first day in intubations as what was an SHO in those days, the answer was not very much. and then they would peer over your shoulder, and they would say, well, what can you see? And we'll try that. And then they did this thing. I don't know if we're being good at this bit, but they did this thing with a handle, and they kind of wiggled it. And suddenly the larynx was as clear as day. Yeah. But nobody could ever tell you what the wiggle thing was. And now as a consultant, I found myself with junior anaesthetists trying to teach them how to do video laryngoscopy or any sort of laryngoscopy. And they don't give you, and you say, well, just do this. What is that? what have you just done that's made the larynx pop into? And I think it's a teaching thing and a training thing. And you can certainly cover the camera screen, or if you have one with a larger screen, you can turn it off or turn it away. So there are ways of teaching direct laryngoscopy with a video laryngoscope. And actually, there are ways of teaching it better. Because nobody sat and taught me about the pharyngeal and laryngeal anatomy whilst I was intubating.
Yes.
Yeah.
If you can both see the screen, you can talk about what you're doing with the blade, where it's meant to be, where it's going, what you can do with the tube to get it in the hole. It opens up a whole revolution. I'll defer to the gang at Bath. Tim and Fiona are fantastic. But they introduced universal VL. And actually everyone was a wee bit anxious because they all said, oh, well, what about all the things we're not going to do? And once they'd had it for 6 months, they were all great fans of it. They said, this is great, because actually we're learning way more. If you've both... I was talking earlier over coffee, so this is the great advantage of being able to talk to people. It's a bit like ultrasound and central lines. And I know that's something that you changed the world for here. Everybody could put in central lines before ultrasound.
Yeah.
But actually, with ultrasound, it's just better.
And where did they put them, was the other question.
Yeah, right. Exactly.
And how much trauma do people inadvertently cause with a direct laryngoscope that they can't see? And that famous line, now it very clearly said you shouldn't do this in 2015 DAS guidelines. That poking a bougie blindly round the back of the epiglottis.
Yes.
Where's it going? Where are you putting that?
Yeah.
It's just not good news.
One of the things that in my institution we actually have been dealing with, because during COVID we were using video laryngoscopy before COVID quite a bit. Not most people were using it specifically for suspected difficult airways, but after there was a widespread adoption, and now we're going to the point of where we're starting to train our we have SRNA students there. We don't have residents, but still very novice and amateurs. And when you come in, there's been a lot of discussions like, are we doing them a disservice? Because there are some nuances between DL and VL. I feel like with how the blade works and whatever it is, the different technologies that you're using, that we may be doing a disservice by not teaching our up and coming on true DL.
That's quite a nuanced subject, and in 2 minutes we'll try and unpick it. The thing is, in 10 years' time, will DL be in the museum round the corner? And I'm not dissing DL. As I say, many consultant anaesthetists for years and many patients have been effectively intubated with a direct laryngoscope. Indeed, if you go back to Shiga's meta-analysis, the incidence of a difficult view, which was essentially the incidence of difficult laryngoscopy because if you couldn't see, you couldn't put the tube in, 6%. So the problem is we're almost trying to solve a problem that is small. But number one, I think VL will replace DL.
Yeah. So
we're not doing them a disservice by
teaching them the technology that we're using.
What I always say to my trainees is, do any of you double D clutch to change gear? And they all look at me and they go, what do you mean double D clutch? And of course, we've moved on from that.
Yeah.
And I guess the other thing is, I think we're not, as long as you teach them.
Yeah.
And that is the key. The key is not, and I think this probably is where the video laryngoscopy debate needs to move. It's no longer just, is video laryngoscopy better? But thanks to Jan and his team, there are 500, this was suggested as pre-meeting reading, actually. Did anyone read all 500 pages? So the evidence is there.
Yeah.
But what we need to change is the idea of how we teach it. Yeah. Because actually, a video laryngoscope isn't the same as a direct laryngoscope. Yeah. It's another tool to do the same job. But we need to start thinking about how we teach it, how we train it, and what we get people to do to implement it.
Yeah.
So we're going to have to wrap in a second, sadly. But you have mentioned a number of times the VLQI or IQ. Tell us a little bit more about that.
It's another one of my surveys, Monty. Around last Christmas, we decided to do a sort of worldwide survey. With EBPOM's help and with some sponsorship from Medtronic, we created a survey in 6 languages. So the questions were all the same, which made analysis slightly easier. And we distributed to all sorts of arts and parts of the country, the world. And we got about 4,500 responses. And the good news is that over 2/3 of the respondents weren't members of an Airway society. Now, you're going to say 5,000 isn't that many, but actually I'm going to say that having 2/3 of the respondents not members of an Airway society is a much more honest representation of the world than if you ask the DAS membership, because we'll all go, use video laryngoscopy.
They're not asking,
And what it shows really interesting, because what do I say? Chris Frurk stood up in Dublin in 2015 when he was asked what video laryngoscope would you recommend. He said, anything hyperangulated. And probably the Airway geeky world has gone on about hyperangulated blades thinking they're cool. And they are. There's evidence in it. But actually, during COVID, the rest of the world weren't really getting into hyperangulated blades at all. They were using Macintosh-style blades. Macintosh-style blades in routine use, the respondents said they about 17% of the time pre-COVID, rocketed to 45% during COVID, and fell back to 30% post-COVID. Hyperangulated blades, 5% pre-COVID. 5%? But we've been talking about hyperangulated blades for difficult airways for ages. But actually in the big bad world, people weren't using hyperangulated blades. 5% pre-COVID, 17% during COVID, falling back to 10% post-COVID. Now, what are the headlines? There are two really big headlines at VLIQ, because you can't read too much into a survey. Number one, routine use of a VL, gone up from 30% to 40%. Massive change. Still not over 50%. We still can't say we're there yet, but a massive change. And the other big change, and this I think is more significant, I would never use one of them because I've never needed to. If you can't get it down with a conventional blade, you're rubbish. 6.5% pre-COVID, 2.1% post-COVID. Now, I've got a question for you. Do you think the biggest group of never users were younger or older than you and me?
Older.
No.
Younger.
Whoa, okay.
Yeah, it was the trainees who were in the not using it routinely. It was the I always thought the reason it took 17 years for a new piece of equipment to be integrated into the NHS was because after 17 years, all the older consultants who'd left the service had gone, and the younger people had gone, this is great.
They hadn't
Is that
seen
retro?
enough
Well,
yet.
I mean, flares came back, you know. Flared trousers came back. That's a bad English joke. we thought they'd
Bell
gone.
bottoms.
We thought they'd gone forever.
No, they're back.
But I think it's a massive teaching thing.
Yeah.
In 10 years, we've come a long way.
Yeah.
But actually, I think we need to stop and go, you know what? I probably shouldn't say this on a national podcast.
That's okay.
One of my registrars came up to me on one of our RITUs during COVID and said, you're doing the ultrasound wrong.
Huge point there.
And
Yep.
I went, it's in the neck. It's in the right place. It's what I've always done.
Yeah.
Yeah, he was right. Because I was growing up when you were telling us we should all be using ultrasound.
Yeah.
And so I learned ultrasound at a kind of ad hoc, not necessarily well-taught, well-structured way. And he was right. Because the internal jugular vein is always about here.
Yep.
I wasn't doing it right. It was where you thought it was going to be.
Yeah.
And I wonder whether laryngoscopy is the same. We actually need to grow up and say, look, this is what we should be doing.
Yeah.
Now let's actually match up. Let's work out how to teach it and how to do it.
Okay. In 2 seconds, what is your ideal laryngoscope? Because you've kind of said it really quickly, but
The ideal laryngoscope is something I can put in my pocket so I can use it wherever I need to be in the hospital, but something that I can beam to a big screen so I can share the view with my trainee or my trainer. And finally, because I know we need evidence these days, it can take a quick image so that I can prove the tube was in the trachea when I put it there.
there you go.
That's a little way away yet.
Yeah, it is a little bit, but we're getting there, aren't we?
Hope so.
Yeah. Alistair, thank you so much
Oh,
for
thank you
taking
for
the
having
time
me.
and coming down and talking
I'm sorry
to
if
us.
I haven't stopped for breath.
They've been wonderful.
You have. It's been great. Thanks, Ian. I really hope we get another chance to talk more about this after hopefully some of this has been disseminated, the Cochrane review that you're talking about. We can have a link to that and to anything else that you want to put into our show notes. We'll definitely link those out.
And I'll put my Twitter address in and people can send me questions.
Would love that.
Perfect.
I don't guarantee to answer them quickly, but I will,
I think that goes for all of us.
we'll get around to them.
Yeah. Well, thank you so much for listening to Top Med Talk. You know, you can always find us on any podcatcher. You can find us on social media, LinkedIn, Facebook, Twitter. We are there. there. Alistair is going to tag us. We'll tag you whenever we post.
Be great.
If there's anything that you hear, you love, give a shout out to us, share with friends. We always appreciate that. Thank you to our sponsors, Medtronic, and all of our sponsors for making everything we do here on Top Med Talk free and open access to the world. Cheers.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.